Okay, we can go ahead and get started. So thank you everyone for joining us for this month's Science Cafe on real world data. For those of you who are not familiar with the CTSC, our goal is to improve the health of those that live in Northern Ohio and beyond by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists, as well as community members. The CTSC is currently doing this by focusing on these five key areas and initiatives. So, resources and services, workforce development, community engagement, health informatics, and clinical and translational funding opportunities. I want to take a moment to introduce both of our speakers for today. So, Dr. David Kaelber is the Chief Health Informatics Officer and VP of Health Informatics and Patient Engagement Technologies. Um, he is also a professor of internal medicine, pediatrics, as well as population and quantitative health sciences at Case Western Reserve University. Uh, He is also the Clinical Informatics Fellowship Program Director, and then within our CTSC, he is the Informatics Module Lead. Also with us today is Dr. Craig Jarrett. He is a cardiothoracic surgeon and a clinical informaticist at university hospitals. He has expertise both in the realm of surgery as well as data science. Dr. Jarrett specializes in advanced structural heart disease treatments, including TAVRs and complex cardiac interventions. So I will turn it over to them to talk about real world data.
Wonderful. Thank you very much, Mackenzie. I'm super excited to be with you all here today. I'm very excited to be sort of sharing the stage, so to speak, with Dr. Jarrett. He and I have known each other for a long time. So I think the way we'll sort of work this is, I'll sort of take the lead. He'll sort of be able to interject some. And then again, I think the idea is, we're probably planning to take up about half the time with the formal presentation, but then really looking for some rich dialogue and discussion, because at the end of the day, Dr. Jarrett and I know how to use these tools. They're helping us a ton with our own research, but we really, really hope through this time together to be able to empower some of you, maybe even all of you, to sort of take the next steps with wherever you are in your own research journey with real world data. So the title of this talk, Real World, and here we're really talking about electronic health record or EHR data, which I believe, and hopefully I can convince you by the end of our time together, that it's really an entire paradigm shift for certain types of clinical research. So we did have an audience participation ask. So, presumably most of you came here because you're already working in some area of research. So even if you don't know that much about real world electronic health record data yet, what we're asking you to do is please put in the chat any potential research questions. Again, not questions about real world data, but if you're a cystic fibrosis researcher or you're a diabetes researcher, any ideas of research that you would hope to do with real world data, even if you don't know if it can be done or not, please start typing those in the chat, and then we'll sort of curate those. It's possible that in parallel, Dr. Jarrett might even be able to work on some of those and get some preliminary data by the end. I don't want to overpromise, but what we'd really like to do is, again, get some ideas of research that you all want to do with real world data, so we can comment on that in the discussion and maybe even start to get some preliminary data for you by the end. Because one of the power of the real world data tools that we have accessible through the CTSC is it just greatly decreases the resources, including time and money, to do certain types of clinical research. So please, start typing some things in the chat about research ideas that you might have in your own area that we'll be able to get to more later. Okay, so we're not all in person, but if we're in person, I love to just have this amazing data. Data is power, and I really believe that. I've sort of lived this for the last basically like 15 years now, and it all started. I'll just give a quick my own personal story into this. So when I was just finished my chief residency, I was medical director for our pediatric weight management program. And I would start to see patients, and I would try to do a very thorough job. And I would start to see that not only did the patient have a weight problem, this is a pediatric obesity clinic, but they had a blood pressure problem. And I started to see this on just, one or two patients a week. But then I had the idea, wow, I wonder if I'm seeing this in one or two of my patients per week. How big of an issue could this be in the Metro Health system? And to me, just going from my clinic to the Metro Health system, I was like, wow, like I could look at thousands of patients. This would be amazing. And so at the time, we didn't have a lot of the tools, needed IRB, lots of things, but basically over the course of about 6 months, like I got some data, and then I was able to find that based on data sitting in the electronic health record, there were about 500 children that had pediatric hypertension, but only about a quarter of them had been ever diagnosed. So as a fellow, I was able to publish this in JAMA, and this was recognized as one of the top 10 breakthroughs of all of stroke and cardiovascular medicine by the American Heart Association back in 2007. So that's when I got the bug that data is power, that you can go from an isolated clinical observation or research question that you might have and really make amazing discoveries through the data that's already just being collected through routine clinical care. So, based on that, early experience where, my God, I thought like 15,000 patients was huge. Now I'm going to be talking to you about things through the CTSC where you can actually access over 300 million patients worth of data. So imagine what I can do with 15,000, what can you do with over 300 million? What are some of the things that we're talking about here when we talk about electronic health record real world data? So first of all, it's about the people. So, as I just mentioned, we have access to two. We'll talk more about this. One is called Trinetics, one is called Cosmos. Both of these have well over 100 million people. The one has about, say, 120, 130 million. The other has over 300 million. Tens of millions of children, if you're interested in pediatric research. It is real world data, right? That's why we're calling it real world data. So, the advantage of real world data is it talks about exactly what's happening in messy clinical care that we're all providing in our healthcare systems today. So it represents what's really happening. That's on the plus side. On the negative side, it's messy. The example I always use, like, have you ever seen, if you've looked at clinical data, like, a growth chart or your weight or whatever that sort of looks like this, and then you have a big point up here or a big point down there? I mean, it's obvious in that sort of situation that that data point is just wrong. Was it measured wrong? Did somebody type it in wrong? Nobody's corrected that. So we know as part of real world data, it is not going to have the same quality as data specifically collected for research in a very quality controlled way. But of course, one of the sometimes criticisms of sort of formal randomized prospective clinical control trials is that the people that actually enroll and the people that complete the study are not necessarily representative of the general population with that disease. So again, pluses and minuses of the real world nature of it. And at least today, I would say in 2026, we're really focused on the structured data. We'll talk a little bit more what that looks like. So we're focused on the structured data in the electronic health record. So to give you some sense of that, what are we talking about? We're talking about patient demographics, medications that have been prescribed, diagnoses that a patient has through ICD coding, procedures that a patient has had. So these are the billing codes that a patient has, typically through common procedural terminology or CPT codes, laboratory values that a patient has, and what those laboratory values were, and then some vital signs and sometimes some other information. But again, it's really all the structured data within the electronic health record. But this has provided us a volume and variety of clinical data that literally has never existed in the history of the world before. And this is really because, I think I talked about this on the next slide, right? So this is really because if you look at what's happened with electronic health records in the US, going back to 2008, right, we had basically low double digits adoption of electronic health records in both the hospital there in blue, as well as the office-based physicians or sort of outpatient ambulatory care in orange. And then we had this sort of proliferation, really an exponential growth in electronic health record adoption from 2008, basically through 2014. Why is that? We can credit the Great Recession. So, because we had the Great Recession back in 2009, one of the parts of the $1 trillion stimulus package there was something called high tech and meaningful use. And it basically gave, there's a lot of details here, but it basically gave about $20 billion of the $1 trillion to catalyze the adoption of electronic health records. And it didn't happen as fast as people wanted, but the reality is basically from 2009, 2010, up through 2014, it made a huge difference. But then what you need to recognize is if we're using electronic health record data for research, it really means, it's going to be pretty robust going back to 2014, 2015. Before that, electronic health records were just not that prolific. And so therefore, there's something unusual about patients with their data in electronic health records. So you just want to be careful with that data. The other synergistic point I'll make here is that in the US, we switched from ICD-9 to ICD-10, basically in Q4 of 2015. So the fact that, robust electronic health record deployment, as well as ICD-10 being deployed basically within about the same year, reaching that the same year, is a big advantage here. But again, it really also means that we're really talking about these tools are going to be really good for looking at things 2014, 2015, and forward. But that's already 10 years worth of data. The other thing I'll usually say when counseling people about using real-world electronic health record data is it's usually much better for what I would call outpatient type of questions versus inpatient or ED questions. Now, again, these are very generalizations, and some questions sort of cross outpatient, inpatient, ED guidelines. But the reason for this is that, in general, data collection, even structured data collection in the inpatient and ED settings is less standard than the outpatient setting. That would be one. And then the second issue is that, in an inpatient setting, there's a lot of data density, right? So a lot of things can happen to a patient on a particular day, lots of lab values, lots of vital signs, potentially lots of diagnoses. And, these tools today generally are less good about sort of disambiguating or sort of visualizing lots of things that happen on the same day. So keep that in mind. I talk a lot about, the three-headed stool or three-legged stool, or the team that you really need to leverage electronic health record or real-world data. So this is sort of the picture of the team. So I'm always using Vern Olacher's picture with her permission at the bottom center there. So she's a medical student we've done a ton of work with. So we need sort of who's the person with the fingers on the keyboard. And again, it can be a medical student. It can be a resident, a PhD student, master's student. These tools, the learning curve on them generally is not that large. It's usually sort of hours to days, not weeks to months. But you need that person who has the fingers on the keyboard. You need the clinical domain expert. And sometimes, these people can be the same person, but you need someone who, even if they don't know how to use the tools or don't know much about real world data, they need to be a clinical domain expert in what area of research is being done. And then, on the right-hand side there, you really need an informaticist / data scientist who really has some experience with electronic health record data, because there are just some nuances or idiosyncrasies with electronic health record data that if you don't have that familiarity yourself, you really want to make sure that there's somebody on the team that can bring that experience to bear. And I think, and we're doing this in the CTSC, although there are hundreds of millions of patients, EHR data is now available, the tools, techniques, and expertise are still rapidly evolving. I'd say our CTSC is one. We just had our external advisory board meeting earlier this week, and literally our external advisors said, you are leading the country in some of the things you're doing in this space at Metro. So some of us on the call are leading the country. We want to enable all of you on this call to be leading in this space in the country, if that's something you'd like to do. Okay, here's a chance for audience participation. And I guess I'll also, I see there are some questions more popping up in the chat. So some of them are probably research ideas that I asked for. But is there someone monitoring the chat so that if it's appropriate to answer one of these questions while I'm going through, we can do that? Or
Yeah,
we wait until the
I'm already
end?
working on the queries for some of them.
Okay,
Yeah.
perfect. Um, Okay, so here's an opportunity for audience participation. So, does anybody know who Thomas Watson was? Feel free to take yourself off mute. So I'd say the most common
IBM,
answer that I get. What's that?
the founder of IBM.
Yes, the founder of IBM. So perfect. Thank you very much, Dr. Nayak. So I'd say the most common answer people typically give me is, was that the Watson and Watson and from Watson and Crick, right, who founded DNA? No, this is Thomas Watson, one of the founders of IBM, right? You can think the Watson supercomputer that won at Jeopardy and beat the world chess champion. So his quote is, the ability to ask the right question is more than half the battle of finding the answer. So I think this is especially true with real world electronic health record data. So again, I'm the first to say, this data and these tools are not going to be able to answer all of your scientifically important questions. One of the secrets to using these tools well, and I'm going to try to, give you the secret so you have them too, is, don't necessarily come with your perfect question and then be frustrated about how the tool can't answer the question. It's better to invest a little bit of time and energy into understanding the types of questions that these tools and this data are going to be great at answering. And then within your area of research, ask the question that's scientifically appropriate, but it's really going to maximize the opportunity of these tools. So I just sort of say that at the bottom, learn about the real world EHR data sets, data platform you want to use first, then formulate your question. And again, many scientifically important questions cannot be answered well by this data in 2025, 2026, and probably, a number of years in the future. But there are a lot that can be. And the really important thing is that many of the questions that can be answered this way have not been asked and answered this way. We've already published some things that are sort of, I would call them almost methods papers to try to help you in this space. So I mentioned Vern Olacker before. So she helped us write this paper. With big data comes big responsibilities, big responsibility. And we really go through a couple dozen things that you really need to think about when you're using real world data, big data. So that's something I would point you to. Published about a year and a half ago now. This is not one of our publications, but I think this article is very good as well. This is the target statement from JAMA that was just published last fall. This is a 21-item checklist when using electronic health record data for retrospective emulation trials. So there's lots of ways to use electronic health records. One of the ways is to basically do a retrospective, prospective, clinical trial based on what naturally happened to patients. That would be a subset of the types of studies that you can do with this sort of data. And there's some special methodological concerns that brings up in ways you want to think about writing up those articles. And so, I think this article is really good in helping to capture all that. I usually show this picture. Again, to me, hopefully it's not daunting to people. Hopefully it's inspiring to people. And so, this is just my own PubMed publications record. Again, everybody can, look at that themselves if they want to. Feel free to look me up. And what you can see is, I felt I was a really successful researcher from 1998 until 2019. I was sort of plugging along with a couple publications a year. Then I got to sort of like 5, 6, 7 publications. I thought this is great. But then, starting in 2020 is when these tools, or I've been working on them for about about a decade, developing them before that, these tools really started to reach their prime. And so you can see, my own publication record really just started to skyrocket. So, 2024, I did 62 peer-reviewed publications. 2025, 96, or excuse me, 69. And I guess I didn't have a chance to re-update this slide. I think when I made this slide, it was in February when I had 16 publications in 2026. Now I think I'm up to like 22 or something like that. So again, to me, this is just it's a really clear indication that it really can, for certain types of research, greatly reduce the resources needed. The resources being money, much less needed, people, much less needed, and therefore time, much less needed. You don't need IRB approval, which I know, again, IRBs are really important, but sometimes that can take a lot of time to go through the IRB. So this is sort of one of the secret sauce slides, but I don't want this to be secret. Feel free to share the slide with your friends. And I'd say it's such an important slide that I've actually included it twice in the presentation. So these are what I would consider ideal real world EHR data study areas. So again, the idea here is that regardless of the research area that you're in, I think these 5 use cases can be applicable to many, many different types of areas and are usually going to be sort of the sweet spot for real world electronic health record data. So let me try to just go through these briefly. And basically, there's the title, sort of the example, and there's actually a reference that I've been involved in that you can look at the publication where we've actually published using this example. So the first one is a simple association. So that's, and we'll talk about this more in a couple of slides, but the example here is semaglutide, which is one of the GLP-1s, and suicidal ideation. So here the idea is there were some case reports that said, wow, it seems like people that were starting on GLP-1s were more likely to commit suicide or have suicidal ideations. Is this a real thing? Well, this is a great type of thing to answer with this sort of data, right? You just take 2 populations, equivalent populations, one prescribed semaglutide, one not, and you just look over a period of time retrospectively and see what's the suicidal ideation rate here, what's the suicidal ideation over here, and compare them. Second example, the second study area is healthcare utilization. So here's a study that we published on the use of Paxlovid when it was one of the first anti-COVID medications to come out. And again, especially at sort of a super large level, people want to know how and where new therapies are being used. And unfortunately, we showed that if you were white, you're more likely to get a prescription of Paxlovid than if you weren't white. Sort of the highlight of that article. Number 3, third area is guideline compliance. So, I love this one. I've done lots of work in guideline compliance. There's a ton of guidelines out there. And I love this because there's sort of no null hypothesis. So, everybody hopes guidelines are followed 100% of the time. I have still not run into any guideline that's followed 100% of the time. If you think there might be one, let me know and we can check it out. And, Cosmos of Trinetics. So, but people want to know, is it followed, 10% of the time, 32% of the time, 75% of the time? And are there patient characteristics or other things that make it more likely to be followed or not? Fourth area, descriptive studies in large or small populations. Particularly, in my pediatric hat, I'm an internist and pediatrician, but on the pediatric side, sometimes one of the major issues is there just aren't enough patients at one institution or even a couple institutions to really understand what's going on. So here's an example of, I worked with a medical student who is now Dr. Klaus, and we basically published this paper on Treacher-Collins syndrome. I think the main reason we got it published is because we were able to say among 1,114 people with Treacher-Collins syndrome, and people just went, what? 1,100 people? We didn't know there were that many people, with that condition. And it could be used for very large studies too. We've done things, what does lupus look like? And, what does that look like across literally tens and even hundreds of thousands of patients? And then the fifth area is population health or chronic disease surveillance. And this sort of gets to the idea that, as I said, the data is very robust, 10 years, maybe you can go back a little bit further, but you can look at trends over time, which again, in some areas of research is very helpful, especially across, tens and tens of millions of people. And then I just put the caveats here, usually going back no more than 10 years, although our RSV study went back to 2010. and sort of more outpatient based. Okay, so here I'm trying to get a little bit more granular now into what are the specific tools and EHR data that we're talking about and that you have access to through the CTSC. So here I'm mentioning some of the ones that, whether you're at Metro, Cleveland Clinic, or UH. If you're at University of Toledo, we just went live with Trinetics. We're hoping to go live with Cosmos by the end of the year. But besides University of Toledo, all the other three main healthcare systems here, we have all of these that I have listed here. So there's always the tried and true EHR data request, manual request of line level data. That's what I did for my pediatric hypertension study. It takes a long time. As I said, it took like 6 months. We needed IRB approval, so that was a process. Then we had to put in a data request. That was a process. Then we finally got all the data. Then we had to do, a whole bunch of our own analysis. So there's IRB needed, no built-in analytics. And at the end of the day, even though at the time I thought, one site, 15,000 patients was amazing, it was only one site. Now at the Metro Health site, we have 1.6 million patients, but 1.6 million pales in comparison to 120 million or 300 million. In all of our Epic sites, there's a self-service tool called Slicer Dicer. If you're not familiar with it, the next time you log into Epic and there's a search bar at the upper top, just type in Slicer. You should have access to it. The nice thing about Slicer Dicer is there's generally no IRB needed if you're just looking at population health counts. There aren't really built-in analytics beside counts. And then it's basically one site again, and only again at Metro 1.6 million patients. So it took away the need for the IRB. It took away the need for the data request. So in that sense, it's savings, but only sort of got you, part of the way there. Now then we have Cosmos, which is an Epic electronic health record, sort of proprietary tool, but we all have access to it through the CTSC. There's no IRB needed. There's still no built-in analytics, really. It uses basically the same thing as a Slicer Dicer, and there's nuances to this. So I'm just trying to give a super high level. But now we've got, over 225 sites and, again, really over 300 million patients. So now we're really starting to leverage the size. And then with Trinetics, which is a CTSC and academic medical center focused, privately funded company where we're giving our data to them and we have free access to the tool. Again, no IRB needed. And one of the huge game changers here, especially for learners, medical students, residents, junior faculty, if you don't have access to robust statistical and data analytics support, Trinetics has built-in analytics, which is a huge game changer. Here we've got over 100 sites and like 120 million patients. Then I just say these tools typically do not allow line level access, but there are some ways to get to line level access. So I want to be transparent about that. But I also want to, if you're doing the line level access, you're not fully embracing the new paradigm because there's going to be a lot more skills you have to have about learning for the data. And then you still just have a data set that you still have to manipulate. Versus if you're using the built-in analytic tools, you're just further decreasing the resources that are needed. But want to make sure that people know there is some line level access with Cosmos and Trinetics. This is just another way. Again, I won't spend a ton of time on this slide, but just sort of looking at some of the characteristics of Trinetics versus Cosmos versus Enact, which is, we're not using it at our CTSC, but some other CTSCs use this. Again, I won't spend a lot of time on this, but you're just sort of going through what are some of the different characteristics. Some of them I've already alluded to, but setup resources are much, much more difficult with something like Enact. Usability, there are sometimes fees if you have external funding for a project. So the way all these tools work is if you're not funded, then the tool is really free for you to use. If you're already getting external funding, like you're writing a grant that's going to use the tool, then you need to write some fees for the use of the tool into the grant that you're applying for. Okay, so here's an example and sort of winding down here in the next 5 minutes or so. So this is a simple association, a medication side effect case. So this is the, and somehow, Yeah. So sorry, I think I misquoted somehow this study, but this study was also done by William Wang, a Pepper Pike high school student. The full reference is back in my 5 types of area slides. I was published in Nature Medicine, a pretty high impact quality medication. So what were we doing here? So as I alluded to before, we had semaglutide had case reports of suicidal ideation when used in patients with obesity and type 2 diabetes. So we wanted to do a retrospective case cohort study using Trinetics. We were able to identify about 250,000 obese patients and 1.5 million patients with type 2 diabetes. And then, some of them were prescribed semaglutide, some of them weren't, obviously not in a randomized control way. Whoever decided that some people get semaglutide, some people wouldn't. And then we looked at incident and recurrent suicidal ideation. And so what did we find? So this just gives you a sense, and again, I won't spend a ton of time, you have the whole reference there, but we're looking at the hazard ratios here. So the idea is if the hazard ratio is less than 1, it's not causing a disproportionate incident or prevalent suicidal ideation. If the hazard ratio happens to be greater than 1, then it's saying that the semaglutide is creating a disproportionate suicidal ideation. So again, what you're seeing here is that everything is to the left of the hazard ratio of 1. So it means there is not a disproportionate association being created here. And so this is in the overweight and obese population. And you can see, again, all of these, the hazard ratio is to the left of 1. So in none of these populations, and we obviously looked at different ages, gender, race, and ethnicity, in none of these cases did it seem to be causing a disproportionate association. And then this is the same idea in the type 2 diabetes population, where again, everything is to the left of a hazard ratio of 1, again, showing that there's not a disproportionate association of suicidal ideation in people when semaglutide is prescribed. So we published this in Nature Medicine in the beginning of 2024. And this got huge public press. So it was over in 100 news outlets. This is just the citation or the picture from the New York Times. This is some more of all the Washington Post, CNN, Forbes. You can see the whole list there. And then within 1 week of the study being published, the US FDA came out with this letter that I'm showing here, basically saying, hey, you don't need to worry about this anymore. There is no disproportionate link. And then about 6 months later, the European equivalent of the FDA basically came out with similar finding, basically citing this study as one of the major reasons for them to say, hey, we don't need to worry about a disproportionate association. Almost finished up here. I did want to sort of put in this one, I would say, sort of special use case that I want to make sure people on this call know about. So, I've been talking about big data, hundreds of millions of patients all around the country, but there's also a special opportunity for anybody that's doing local research and potentially, interventions locally. So because Metro Health, Cleveland Clinic, university hospitals, as well as a number of our federally qualified healthcare centers and people like Akron Children's Hospital and others are all on Epic contributing to Cosmos. We have 83% of the Cuyahoga County population that's deduplicated, right? Because we know people get a lot of care at multiple healthcare systems. So this is deduplicated, is searchable down to the zip code level. So again, I would say being in this space for a couple of decades now, this is something that people have asked for in Cuyahoga County literally for decades. And we never had an easy way to put this together until now. So this resource is now available. I'm super excited to call out the Better Health Partnership, which I know, a number of the healthcare institutions are involved in. This is the first group that I'm aware of that has leveraged this to look at community pediatric, anything at the community level. They looked at community pediatric screening rates, and then are doing community-based interventions and measuring the impact of those interventions through Cosmos throughout the community. So just want to make sure it's a little bit of a niche use case, but for anybody that's doing sort of population health for quality improvement, quality interventions within the local area, this is a resource that's never been available before. Okay, I said that this slide was so important. I was going to show it to you twice, so I'm showing it to you again. Again, just these are probably the 5 types, if you're just getting started in this space, the 5 types of study areas that you want to think about. And then sort of opportunity for conclusions, questions, discussion. So, real world EHR data have never existed in the history of the world like now. So it's a huge CTSC opportunity, both for those of us in informatics to develop tools, techniques, and expertise. And then because we've been doing this for several years, for all of you to start to take advantage of this in your own research. Remember the 3-legged stool. Remember, Mr. Watson, the right question is extremely important. But as number 4 there, for certain types of clinical research questions, real-world EHR data greatly reduces the resources needed, and so can exponentially increase your research productivity. And again, I'd say my PubMed citations sort of speak for themselves. So I think with that, have any questions? This is if you want additional information, really recommend you check out the CTSC website. We give big data quarterly lectures, and they're all recorded there. So you've got 4 or 5 that are already recorded. We have big data office hours that are listed there. We have an annual Cosmos Datathon that we've done 2 of, and we'll be doing another one in fall. And of course, there's always the Spark request. We'll do individual consultations as well. So with that, I'll end the formal parts. I don't know. I can turn it over to you, Dr. Jarrett, if you had any questions, or if you've already been working on queries, or if there are other questions in the chat that that we want to respond to.
Yeah, so there are quite a few really good ideas in the chat. So I've been working through some of those. I can take over here. And so Dr. McCumsey asked long-term COVID effects on cancer risk. Let's see if that's finished running. Looks like it's close. So this is Trinetics. And so this question, because there's a nuance, you want to look at the temporal event of having COVID first and then developing cancer. There, you can do that in either or Trinetics or Cosmos, and or in the data science virtual machine, which is the line level data of Cosmos. It's a little bit easier in Trinetics. The main reason is matching of patients. So in Cosmos Slicer Dicer, you really can't propensity match patients like you can in Trinetics. You can definitely do propensity matching in Cosmos Data Science Virtual Machine, but that's a whole that's the small percent. And as Dr. Kaelber mentioned, if you're not asking the right question and you're asking for the line level data, you may not be using the tool correctly. You may not be using the tool to the best of the ability or the way it was designed to be used. And so I'll show that in both interfaces real quick, and then we'll jump into I got through the second, and there's which is how many older or how many adults have advanced care planning conversations with their physicians that's covered by Medicare. So adults as in 65 years or older. Which chronic diseases are prevalent in rural areas of northern Ohio? So that's a good one for Cosmos Slicer Dicer, because there is for the Slicer Dicer, you can get down to county level and even deeper into with geographic, like a map, like a sys map. We're showing you their different counties. I didn't do that one because that's a little bit more involved, but that's definitely an option. And then I was working currently on the prevalence of prediabetes among teens. That's a really good one for Slicer Dicer. It's quick. So and then we can talk through if we have time on the feasibility of these other ones. But I guess first come, first serve for this purpose. So the long-term
And
COVID effects. Go ahead.
well, I just say, I think one of the things, just at a high level, because a lot of people, we get a frequent request to sort of look at cancer. And I just think, it's not that we can't do it. I think you just have to be thoughtful of sort of the temporal process that you think is happening.
Yeah.
To me, usually cancer is like a long-term thing. And so, probably looking at COVID and cancer will be a great question to try to ask in like 10 or 15 years. I guess it all depends on the biological plausibility mechanism. You think that, that you're going to see a cancer that was created by COVID, if you just had COVID, in the last year or two. And again, maybe there's a good biological plausibility hypothesis, but you just want to think about what's the normal temporal sequence with which you think things will happen, and how, is Trinetics at this point, or Cosmos, is there enough longitudinal data to measure what you think you can measure? Looks like
Go
Dr.
ahead.
McComsey has her hand up. You want to comment?
Yeah, so David, I mean, you're right, it takes time, but I think, some groups have seen an early signal and it's been 6 years. I think it's important, and that's why I wanted to ask Craig. So did you take only people who had at least one visit in the year before COVID? Because obviously people may have had the cancer, they never showed up. And then suddenly we see it, right? And it has nothing to do with COVID. So what did you do with the period before COVID?
Yeah, and I can show that. So again, this is because I'm doing it in real time. It's very crude. So this would need some polishing, but because of what Dr. Kaelber said, it's probably gonna take some time to see the cancer. So I thought, well, cancer is more prevalent in older people, not children necessarily. So I first thing I did, and to make the query run faster. So again, if we're doing this in real time, this is a kind of I'd call it a dirty query. I just put in over 50 years, right? Because that basically cuts the population pretty much in half, and it just ran quicker. So the one thing I did is, and I'll show you where you have to have the index event of which is uh, you have to have COVID. And the one thing I didn't put in here, because obviously patients with cancer uh, are more likely to have recurrent cancer, right? Or another form of cancer, right? So that probably should be discussed and put in the cannot have. So this is Trinetics. It's called the query builder for those who have not seen it. But it's pretty straightforward. The things you want, these are your inclusion criteria on the left, exclusion criteria on the right. And so for this exact query, we probably should put they shouldn't have, XYZ cancers, maybe focus on a specific cancer and do another query. You can also get rid of that for propensity and the propensity matching. And that's why I jumped to Trinetics, because really, if you're looking at an index event and trying to follow it over time, you do need to match the patients kind of at the time of the index event. So there are currently 50 or adults, so over 50, that had a positive COVID diagnosis, and so that again, you have to go down all these rabbit holes, but you can pull this up, and they'll show you the hierarchy here, and so how they came up with that. You can see the
Right,
spinning wheel down here.
yeah, you can pretty much say first COVID, right? So if they had
Yeah.
none, they were talking first.
Yeah. So first COVID, they're considered, and that's what you said as the index event. So that is the COVID positive group. I, of course, created a COVID negative group, again, age 50 or older. The one thing that was important to do is you have to have an index event. So these, if they don't have evidence of having COVID, did they just not, were they never seen, right? So they have to have a visit. And their first visit is the index event, and then they never get COVID in between the study period. And so that's COVID positive and COVID negative groups. And then you can jump into all these. We're not going to do that now, but in the analytics section, and this is the one I started, but if you go to the new analyses, this is where Dr. Kaelber was saying you don't necessarily need to know how to do Cox regression or logistic regression or propensity matching for that matter. You can kind of use the user interface as a guide, with a caveat of you have to be very careful of how you report these things, because you can. Again, not to dig it in too deep, but there are some subtle errors or subtle ways that if you ask a statistician, we probably shouldn't be reporting a zero censored right skewed distribution with mean and standard deviation. Like that's a no-no, but you'll see that. And so anyway, so just keep your statisticians involved, but it does make it a lot easier. I'll go into now that query builder, and so the one I picked, and I guess I didn't show that, but the one I picked was this compare outcomes. So you have it shows here two cohorts. You have an index event. You want to compare characteristics before that index event and make sure that the groups are somewhat similar. And then you want to review the outcomes. This is did they develop cancer? And so I picked this one. I'm going to go back because I already started it and it took a little bit to run. And it's easy as dragging and dropping. So I drove the COVID. This is the population from the query builder. So these are the included patients. And then let's just think of your table one. So how are you going to divide that table up in between the columns, right? You have the COVID group and the non-COVID group. And so it's easy as dragging and dropping. And then you go into the characters. This is where you have to pick that index event. And so the index event is COVID. And so um, the time window this is kind of the default time window, but it's basically any time from the time which we're calling now, anytime prior to that. And then in the subsequent explore outcomes, you will actually set that they have to have the index or the outcome of interest, which is cancer, after the index event. And this is, to take a step back, if you're looking at something like I wanted to look at um, mechanical ventilation times in postoperative patients. Like that's not a question that can be answered using these databases because the most granular data you can get is is really by the day. And so that's a small thing you have to look at. And after you run this, you can go through the demographics and basically this is your opportunity to look and it will show you once it finishes again, the real-time data is a little bit challenging, but I already ran this, and so you'll see here, you can start to see, um, you know, the between the purple, which is cohort one, COVID positive, and the green, which is cohort two, COVID negative, you can start to see, subtle. These are may or may not be statistically significant differences in, like, for instance, demographics. And then you go through, and you can look at oncology. You basically look and the way you would do this in a norm in a if you just had the actual data is you do a univariate analysis, right? Look for a p-value greater than maybe zero point 0.2, and then add that to your multivariate regression or multivariable regression. But here you can kind of look. And so what you do is you look through the ones that you want to put into your propensity matching. You basically can star those. They come down here as the saved characteristics. And then you can, so again, I starred these, I just did age and gender, basically. And I guess I didn't run it. We'll run this. And this is the real part that to show in real time is quite difficult. But once this runs, you'll get the baseline comparison for those exact variables. You can then add them to balance your cohorts using the propensity matching, and then you would explore your outcomes. You could put and using the same search interface, you can put a specific kind of cancer, and or you can put any cancer. You can do the way both of these databases work is you can put in an ICD code, which is those are hierarchical. So if you put like I30, it's going to be all the subsequent children of that parent code. So I'll let that run. We'll come back to it. I'm going to jump over to Cosmos to show what that would look like for some of these. So, uh, how many older adults have advanced care? Let's look at that one. And so that is here, advanced care planning. So again, I did this is again, this took me 2 minutes and the bulk of it is just waiting for the waiting for the data to kind of run. But the way you can answer this question is how many older adults have advanced care planning conversations with their physicians that is covered by Medicare? So you have to take a couple of assumptions there. That number one, if you assume that if a patient had advanced care planning a conversation with their physician, that it's documented, right? We don't, at least in, there are features, they're very new in Trinetics, and they're coming. I think they're going to be in both, where you can look at the unstructured pieces of the notes. You can do that in your own. So this is slicer dicer Cosmos. There's a slicer dicer in every Epic instance. So Metro will have a slicer dicer that's specific to them. University hospitals have a slicer dicer. So those features do exist already. I think they're going to be hopefully coming to Cosmos, but not yet. And Trinetics has some features where you can look at the unstructured data. But the important point here is for this question, in the current state, you have to assume that if there was a conversation, that it was documented in the note with an ICD code, and there is, or it's a CPT code, I'm sorry. And so that CPT code is here. Let's go through the whole query. So I did all patients, and I did patients over 65 so that they're Medicare eligible. And then they had to have a diagnose, or they had to have, here we go. So then, yeah, okay. So these are patients who have had um, a CPT code listed here. I'm trying to show you the group. There we go. So these are the two CPT codes. Oh, let's go back. Undo. They have this nice little undo feature here if you make a silly mistake.
And I will point out, Craig, while you're working on that, I think this is an example too where, again, we can just, for those of us clinicians, it's one thing to have the discussion about advanced care planning. It's another thing to bill for the discussion about the advanced care planning, right? So what you're seeing here is that if it's billed for, that's the breadcrumb that we're able to track and count. If the discussion was had and documented but not billed for, it's going to look like it didn't happen, even though it did, because as that, we can't actually find, there has to be that ICD code, there has to be that CPT code type of thing.
And so here they are, the CPT codes 99497 and 99498. So for 30 minutes, an additional 30. And so you basically create a group that includes both of those. And that is as you hover here, you can see the other one kind of disappears. So if they had a CPT code, these are now, and again, you can put in the start date. I did January 1st, 2017, to the most recent update of Cosmos was February 24th, 2026. So a couple weeks ago. But I did 2017 because that's at least when ICD codes changes. So I started off with looking at ICDs, and then I'm like, no, this is a CPT code. So anyway, this could be changed. But so it looks like you can get raw counts, and so that's a number of patients that basically are 65 again. And the better way to do this would be to look at like you know maybe a Medicare wellness visit, or again, I'm not a primary care physician, so I don't. I assume these would probably make their way onto that visit, but maybe not. Um, and so it looks, you can change the measurement here. So number of patients, you can change it to instead of you can do a ratio. Distinct count is what we're currently doing. Um, and you can get basic pictures like this. Um, so it looks like, a third-ish of adults over 65 have a build procedure for advanced care planning. And then, so if we wanted to, let's take a look back now at the other. I'm sorry to flip-flop, but unfortunately, we just to save time. So back to the long-term COVID effects on cancer. And so the baseline characteristics now that they've run, we're sorry, there was a problem on our end. Please refresh your browser. That's wonderful. We'll see what
Let me,
happens.
if I can I take the screen for a second,
Yeah,
Craig? I wanted to get to, while Craig was showing, I was trying to multitask too. So I wanted to get to Shannon's questions. I think that's important for our CTSC.
go ahead. Can you
So if you
take,
can see this,
I think you still have
yeah,
to
can you
take
see
over.
my screen?
My
People see my
screen's still
screen, okay?
highlighted.
Yes, we can see yours, Dr. Kaelber.
Okay, great.
Okay. So again, part of the problem is I don't know what the rural counties are. So I literally just did all counties in the state of Ohio, but literally just within 5 minutes here, and I can tell you what the top 6 diagnoses are. They're essential hypertension, hyperlipidemia, GERD, anxiety, other chronic pain, vitamin D deficiency, and I have that at the county level now. Right. So again, to me, this is extreme. I mean, and we can easily take away the ones that aren't rural. So if someone can provide me what the counties are, or if they're zip codes, I don't know how we're defining rural, it would be very easy to do this analysis. And it just is just top picking the top 10 ICD codes. So I mean, I know this is a priority for the CTSC, so love to help more with that, or if there's someone else on the team that we want to educate to use this tool. But I think this tool would be, in an afternoon with the right people, we could easily get a very good preliminary list of what are the top 5, the top 10, the top 50 encounter diagnoses for patients in the rural catchment areas associated with our CTSC. Turn it back over to you, Craig.
I think we only have 2 minutes here, so we'll
I mean, hopefully this was meant to be the teaser session. I mean, there's no way we could like impart everything from our brains about these in an hour, but really hoping that for a lot of you, this stimulates you to take the next step. And so if that next step is to come to view one of our historical, or come to one of our big data talks, that would be great. If it stimulates you to if you're already using some of these tools and you want to come to our office hours, that would be great. If you want a more in-depth conversation with one of us, and it's not just the 2 of us, we have other people on the team, we're happy to set up a research informatics spark request and meet with you for a half an hour to talk more about how you think you can use these tools so that you can be super productive as well. We're happy. I mean, I know we're out of time. I'm happy to stay on for another 5 or 10 minutes if people have other questions they want to talk to me about, but I know we're at the top of the hour.
Well, thank you so much for that.